Hello everyone, this is Dr. Sangeeta Chaudhary once again and I welcome everyone to my lecture class. In today's class, I am going to discuss about diabetes mellitus. We all have heard about diabetes mellitus. So it is very important that we know about diabetes, its management and how we treat a case of diabetes mellitus. So today's class, I will discuss about the diagnostic criteria of diabetes mellitus. I will discuss about the classification of diabetes mellitus and I will talk a little bit about the pathophysiology of different variety of diabetes. So let's begin with the diabetes mellitus introduction. What is diabetes? Basically, it is a group of common metabolic disorders which share a common phenotype of hyperglycemia. So the hyperglycemia is the most important word. Okay. It is caused by a complex interaction of genetic factors as well as environmental factors. It is not that every person develops diabetes or every person will develop diabetes. It is those who are genetically susceptible, only them, they will develop diabetes. So there should be an interaction between these genetic factors and the environmental factors, which ultimately results in the development of diabetes mellitus. Why hyperglycemia? What are the reasons of developing hyperglycemia? It may be as a result of reduced insulin secretion, decreased glucose utilization, and increased glucose production. So these are the causes of hyperglycemia, which is the common phenotype for diabetes mellitus patient. Now, coming to the diagnostic criteria, this diagnostic criteria is by ADA, that is American Diabetic Association. Okay, so as per the ADA diagnostic criteria, if someone has symptoms suggestive of diabetes mellitus along with random blood glucose 200 or more, then the person will be diagnosed as having diabetes. Okay, symptoms of diabetes plus random blood glucose 200 or more milligram per deciliter. Or if the fasting glucose is 126 or more, or hemoglobin A1C, that is HbA1c 6.5 or more, or 2-hour plasma glucose, okay, after oral glucose tolerance test, if it is 200 or more, then the patient will be diagnosed as diabetes mellitus patient. Okay. So symptoms plus random blood sugar more than or equal to 200, or fasting blood sugar 126 or more, or 2-hour postprandial after oral glucose tolerance test 200 or more, or HbA1c 6.5 or more. Okay. All these situations will lead to the diagnosis of diabetes mellitus. So this is about the diagnostic criteria. I was talking about classification of diabetes. Okay, commonly we only know that there is something like diabetes mellitus, but we do not very often know or discuss about the classification of diabetes. So if I talk about the classification, there are two main variety or main types of diabetes. That is type 1 diabetes mellitus and type 2 diabetes mellitus. Okay. Type 1 diabetes mellitus, it is basically immune mediated. Okay, there is immune mediated destruction of the beta cell of pancreas, which ultimately leads to absolute insulin deficiency. That is the pathophysiology of type 1 diabetes, means the insulin secreting beta cells will be destroyed in the process of some autoimmunity. Okay, and because of the destruction of the beta cells, the patient will not be able to produce insulin, ultimately leading to absolute insulin deficiency, okay, which leads to type 1 diabetes mellitus. Now, type 2 diabetes mellitus. Type 2 diabetes mellitus, the main important pathophysiology behind this is insulin resistance. Development of insulin resistance leading to less utilization of glucose leads to type 2 diabetes mellitus. There are certain specific type of diabetes. Okay, Genetic defects of beta cell development or functions, okay, characterized by mutations in various genes like hepatocyte nuclear transcription factor HNF4 alpha, okay, mutation in this leads to MODY1. MODY, MODY stands for maturity onset diabetes of young. Maturity onset diabetes of young, MODY1. Glucokinase, MODY2, HNF1 alpha, MODY3, some others like insulin promoter factor 1, okay, problem in the insulin subunits of ATP sensitive potassium channel, mitochondrial DNA, other genetic mutations leads to certain genetic types of diabetes mellitus. Okay. There may be transient neonatal diabetes, okay, in case of newborns. Diseases of the exocrine pancreas, okay, diseases of the exocrine pancreas, for example, pancreatitis, pancreatectomy, pancreatic cancer, fibrosis, cystic fibrosis, hemochromatosis, then fibrocalcific pancreatic disease, all these may lead to development of diabetes. Genetic defects in insulin action, okay, may lead to diabetes. Certain endocrinopathies, okay, for example, acromegaly, Cushing's disease, okay, glucagonoma, pheochromocytoma, hypothyroidism, somatostatinoma, aldosteronoma. These are few endocrinal causes of development of diabetes. Okay. Diabetes may be as a result of certain drug use or chemical induced diabetes. For example, a very good example will be steroid induced diabetes. Okay, glucocorticoids, long term use of high dose of glucocorticoids results in the development of diabetes. So, that is one of the common example of drug induced diabetes. Others like pentamidine, nicotinic acid, diazoxide, beta agonists, thiazides. Okay, there are so many drugs. Okay, the list is long, which may result in the development of diabetes. Infections, certain infections, as I was talking about, environmental factors also play an important role in the development of diabetes. So certain infections like congenital rubella, cytomegalovirus, Coxsackie virus infections, so these are associated with the development of diabetes. Certain uncommon forms of immune mediated diabetes like stiff person syndrome, anti-insulin receptor antibodies. Okay, certain these are uncommon causes of diabetes. There are other genetic or chromosomal disorders which may also result in the development of diabetes. For example, so common examples will be Down syndrome, Klinefelter-Turner syndrome. They are prone to develop diabetes in their lifetime. Lastly, gestational diabetes mellitus. As the name suggests, gestational, that means during the antenatal period, a mother develops diabetes, so gestational diabetes. I will discuss about the pathophysiology of the common types of diabetes, and regarding the gestational diabetes, I will discuss about GDM in one of my lecture class. Now, coming to the risk factors for development of type 2 diabetes mellitus, which is very important for us to know, for practicing doctors to know, as well as for the community also. It is very important that we know about the risk factors of development of diabetes so that we can, if the risk factors are modifiable, we can modify, or at least we should try to modify the risk factors. So what are the risk factors? Some risk factors, of course, they will be non-modifiable, means we will not be able to do anything for them, but some of them will really be modifiable. Family history of diabetes, non-modifiable risk factor, you cannot do anything if your family member had diabetes, parent or sibling with type 2 diabetes. Overweight or obese, modifiable risk factor. Weight reduction is very important. Okay. Physical inactivity, modifiable. Okay. Race or ethnicity, non-modifiable. Diabetes is common in African American, Latino, Native American, Asian American, and Pacific Islander. Previously identified with impaired fasting glucose, impaired glucose tolerance, or an HbA1c of 5.7 to 6.4. While I was discussing the diagnostic criteria, there I said if HbA1c is 6.5 or more, they are considered as diabetes mellitus. But if it is below 6.5 but above 5.7, then it is called as impaired HbA1c. Okay. Impaired fasting means if the blood glucose is in between 100 to 125, then the person will be considered as having impaired fasting glucose. Impaired glucose tolerance if 2 hours postprandial blood glucose is in between 140 to 199. Okay, they'll be considered as having impaired glucose tolerance. History of gestational diabetes mellitus, those mother who develops GDM during pregnancy, they do tend to develop overt diabetes in future. Okay, so they should be monitored. Hypertension, hypertensive patient, they also do have increased risk of development of diabetes. Level of HDL cholesterol, we all know that HDL cholesterol is the good cholesterol, and the level of HDL, if it is low, less than 35, and triglyceride level more than 250, that again forms a risk factor for the development of diabetes. Polycystic ovarian syndrome, okay, or acanthosis nigricans, risk factor for development of diabetes, and history of cardiovascular disease. So these are the risk factors, important modifiable and non-modifiable risk factors, which we all should know about, okay, so that we can do something to reduce the risk factors for the development of diabetes. Pathophysiology of different type of diabetes. Type 1 diabetes, as I said, it is immune mediated. Okay, there will be immune mediated destruction of the beta cells resulting in reduction in insulin secretion. So autoimmune destruction of beta cell. Type 1 diabetes constitutes around 5 to 10% of diabetes mellitus. Okay. There will be presence of islet cell autoantibodies. Since it is an autoimmune process, there will be autoantibodies. Okay, and they will be directed against different pancreatic islet molecules such as GAD, insulin, okay, IA2, ICA512, and zinc transporter 8. There is strong HLA association in type 1 diabetes. Okay, these HLA DQA10301, DQB10302, and DQB10201. These are very importantly associated with type 1 diabetes. Actually, these are important for the competitive exams or MCQ purpose. Okay, so please try to remember this HL association. Type 1 diabetes, since it is an autoimmune process going on inside the patient's body, so they are prone to develop other autoimmune diseases as well. For example, they may develop Graves' disease, Hashimoto's thyroiditis, vitiligo, Crohn's disease, autoimmune hepatitis, myasthenia gravis, and pernicious anemia. Okay, so they are prone to develop this group of autoimmune diseases in their lifetime. This is about type 1 diabetes mellitus. Okay. The onset of type 1 is usually in young population. Okay, onset is it is before 30 years of age. And if we look at the body habitus, they are usually lean. Okay, they do have a lean body habitus, and they do require insulin as the initial therapy because there is absolute insulin deficiency. That is the main pathophysiology. Since there is insulin deficiency, they will definitely require insulin from the very beginning of the diagnosis. And they do have a tendency or propensity to develop diabetic ketoacidosis. Okay. So diabetic ketoacidosis is one of the medical emergency. It is one of the complication of diabetes, and it is much associated with type 1 diabetes than type 2 diabetes. Okay. So this is just the pathophysiology, graphical representation of the pathophysiology which I have just now discussed. As I said, if there is interaction between the genetic factors, so there should be genetic predisposition and certain environmental factors which may act as immunological trigger. Ultimately, will result in immunological abnormalities, and there will be progressive impairment in the beta cell function. Then the beta cell will be destroyed. They will not be able to produce insulin. Ultimately, the patient will develop overt diabetes over a period of years. Okay, this is about the pathophysiology of type 1 diabetes. Now, a little bit about type 2 diabetes, which is the most common form of diabetes. Okay, so 90 to 95% of diabetes mellitus patients are of type 2 diabetes. Type 2 has a strong genetic predisposition. Okay, and the main pathophysiology, as I said, in type 2, it is the insulin resistance at receptor level. Okay, insulin resistance at receptor level. Diabetic ketoacidosis does not occur so often as like type 1 diabetes. Okay, they are frequently undiagnosed. Okay, that is the main fear. They remain undiagnosed for many years. Okay, and usually they present with complications to us. Okay, because hyperglycemia in type 2 diabetes it develops gradually as the resistance builds up, then the patient gradually develops hyperglycemia over a period of years. So the presentation, most of the time the presentation is with complications of type 2 diabetes mellitus. Okay, the onset, as I said, in type 1 onset is before 30 years, but in this onset is after, usually after age of 30 years. Type 1 diabetes patient, they are lean. Okay, they have lean body habitus. Opposite in type 2, they do have a overweight phenotype. They're usually obese. 80% are obese. Okay, but elderly individuals may be lean as well. They may not require insulin therapy at the very beginning. If they are diagnosed at an early stage, they will not require insulin therapy at the very beginning. Unlike type 1, where they do require insulin as soon as the diagnosis is made because they have an absolute insulin deficiency. Okay? They type 2 diabetes they may be associated with conditions such as insulin resistance, hypertension, cardiovascular disease, dyslipidemia, and polycystic ovarian syndrome. So these are associated diseases or comorbidities of type 2 diabetes. Now, if you look at this graph, okay, this is the insulin secretion, okay, and this represents insulin sensitivity. Okay, as the insulin sensitivity reduces, that means as the insulin resistance increases, the insulin secretion also increases. That means our body tries to compensate for the resistance. If the resistance is more at the receptor level, then the pancreatic beta cell will try to increase the insulin secretion. So in this graph, if we see that over a period of time, if the sensitivity is reducing, okay, by the time the patient reaches from A to B point, okay, that means sensitivity is reducing, okay, sensitivity gets reduced, okay, insulin secretion increases. But if at some point of time the body will not be able to increase the release of insulin, okay, there will be exhaustion of the beta cells and beta cells will not be able to increase the release of insulin. Okay, in that case the patient develops overt type 2 diabetes. Okay, so this is about the graph here. There is something known as LADA, LADA. Okay, what is LADA? It is one of the variety of diabetes. Okay, it is known as late onset diabetes of adult. Okay, it is adult age. The person is usually adult at the time of diagnosis. There is presence of autoantibodies. Okay, delay from diagnosis in the need for insulin therapy. Okay, that means this group of patients they are usually adult, okay, at the time of when the diagnosis is made. They do have autoantibodies, okay, and they usually do not require insulin at the time of diagnosis. First and last are not categorical traits, of course. LADA patients should be diagnosed with non-insulin requiring diabetes at age 30 years or older. So age is 30 or more. They do have autoantibodies, but they do not require insulin from the very beginning of the diagnosis. Patient who had 6 months without insulin treatment after diagnosis, that means there should be at least a gap of 6 months after the diagnosis where the patient do not require insulin. But if the patient has autoantibodies and the patient requires insulin from the very beginning of the diagnosis, that will be categorized as type 1 diabetes, not LADA. Okay. MODI. Okay, MODI stands for maturity onset diabetes of young. This is again one of the other variety, not so common, but we need to know about this. One of the other variety of diabetes. The diagnosis is made early, before 25 years in at least one and ideally two family members. Okay, it runs in the family. So they are not insulin dependent. It has autosomal dominant inheritance. Okay, they are not obese, rarely obese, and diabetes results from beta cell dysfunction. So these are the important, characteristics of maturity onset diabetes of young. These are important for competitive exam point of view, MCQ point of view. These are very important. Okay. Lastly, a little bit about history. Okay, when we take history, there are certain points which we should be remembering. Okay, a complete medical history should be taken. Current weight as well as any recent changes in the weight should be noticed. Family history of diabetes and its complications should be asked about. Risk factors for cardiovascular disease or any risk factor for the development of type 2 diabetes is there or not should be sought for. Okay, it's history regarding if the patient does any regular exercise or not. What about the physical activity? Smoking status, history of any pancreatic disease, ethanol use. These are the things we should be asking or we should be really noting down from the history. So, this is about this class where I wanted to talk about different varieties of diabetes, how do we diagnose diabetes, and the classification of diabetes. So, thank you so much for attending the class. I hope this class will be helpful for you. Thank you.